Really awesome that we can do this virtually, and thank you for taking time out of your busy schedule. I'm Mark McGovern, and I'm a professor at Stanford in psychiatry and in medicine, and I have done a lot of work over the years in the field of addiction, and more recently implementation science and practice, which is really about trying to implement evidence-based interventions, whether they're medications or psychosocial treatments that are effective, but often not widely available or equitably available to the people who need the who need the kind of treatments and services that we know are best in terms of effectiveness. So, just by way of background, I have a history with the Root Center and clinics. When it was called the Hartford Dispensary, and I don't know how many of you were with the Hartford Dispensary before it became Root, but I think it goes back to the early 2000s, maybe 2005 to 2015 or so. I worked closely with your clinics on Weston Street in New Britain, downtown, and really did a lot across all of the locations. I don't think the Manchester site, the home office, if you will, was set up at that point. Mm-hmm. But it really was a great pleasure, very rewarding, excellent people, I think really good work. It was largely focused on integrated care for patients in methadone treatment who had co-occurring psychiatric disorders. So that was what we did, and we focused on training and implementation support. Actually studied an intervention for patients that had comorbid PTSD, and we had a manual guided treatment. We translated it into Spanish for Spanish-speaking patients. And it was very effective, but the best part was that we trained counselors to deliver the intervention, and I really got to meet some really awesome people. So there's really a soft spot in my heart for the Hartford Dispensary and all the work you do. And I know things have changed, but I think there's still a part of me that really admires the work you do and the service you do. So I think I did think I was going to share slides, but I don't think I'm going to bother. I'll just talk a little. So yeah, one of the things that I was at Dartmouth, so I was in New England, and I'm a New Englander. I was born in Rhode Island and raised up that way, and did a lot of work coming down from Vermont and New Hampshire to work with you all in Connecticut, which was also good, especially in terms of the different kind of restaurants I could get to in Connecticut versus what was available in northern New England, which is kind of slim. But I think one of the things that I learned was that methadone treatment and OTPs are like really critically important, and if anything, kind of what I thought of at the time, the future of addiction treatment. And I just really want to commend that work you're doing in your day-to-day, dealing with some very complex patients under really extraordinary circumstances with lots of social determinants and risk factors that affect people and their outcomes and their ability to participate in treatment, and really benefit from, the power of the medication and the counseling that you offer. One of the things that I've been doing since I got to Stanford is really working a lot with, like I said, implementation and the science of implementation to improve people's chances of getting good care. And I think as COVID came about, we noticed that there were many adjustments to things that we've been doing forever. And I'm in a department of psychiatry. I see patients. I had never imagined that, doing telehealth and telemedicine and telepsychiatry would work out. It's just not anything I thought was doable. And lo and behold, although I don't know that we know fully how it's worked out, it did seem to have a reasonable effectiveness. But one of the other things about being here at Stanford is that I'm in Silicon Valley, which is the land of the Elon Musk and the Googles and the Facebooks and all of the other innovations that happen here and then spark change across the country. So I get invited all the time as kind of an academic, within an academic institution, that has a good reputation. I get invited to serve on advisory boards and, a consultant on different innovations, from apps to web-based therapies to avatar therapies to you name it, people have thought of it. And I've always been suspicious, and I've always said no to these invitations. And but one came along, through a colleague. Actually, Dennis McCarty is the colleague, and he was at Oregon Health and Sciences University. And I actually knew Dennis because he was a state agency director for Massachusetts for many years when he was, and then he transitioned from that position to Brandeis. So another New Englander out to the West Coast. But Dennis contacted me and said, Mark, there's this group of really smart people who are innovating and, a way for people to have take-home methadone doses in a way that is not, is not entirely loose. It's a way to monitor people in a way that, might increase the chances of people being able to continue in treatment and also respect the kind of the challenges that people might have in coming to a clinic for daily dosing. And that could be the single mom with, kids that, has shaky transportation, or, the day labor worker, who needs to show up, early in the morning, at a job site in order to get paid for that day to support his family. All the reasons that you all know of that kind of present challenges. And we do know that there's a rationale for the way we've been delivering methadone in terms of adherence and, prevention of diversion, opportunity to engage in counseling, to address some of the drivers to addiction, relapse, and maybe the benefits of recovery. So we do know that things were put in place for a reason, but that maybe there's some questions as, especially I think with COVID and changes in the regulations, if those things are necessary for all patients, and sort of challenge a little bit our way of doing business. And so Dennis introduced me to Michael and colleagues, and I just thought, wow, this is really something that seems motivated by humanity, not motivated by profit, motivated by, trying to, aligning with my values, getting the best care possible to the people who need it most, and not in a punitive way, not in a judgmental way, not in an unreasonable, loose way, zero barrier way, but really in a way that could optimize the benefit of this really potentially transforming medication. So I said yes. I said I'm interested in these folks, and got to ride shotgun with them on a few different projects. Specifically one with an OTP out here in San Francisco, the BART clinic, which is in a rough area of San Francisco, right off Market Street. And I got to see firsthand the benefits to the patients, just in terms of the new freedom, the new trust that was established, but also watching the clinic itself, everyone from the nurses to the counselors to leadership saying, this is really cool. We think that this is this is something that we'd like to keep going. So since then, and Michael will tell you all about this, I think that there's been a slow and steady growth. They're approaching this very scientifically as well, carefully studying impact and outcomes and feasibility and appropriateness, all those kind of things that you would expect, from like an approach to getting FDA approval for medication. So I guess I just want to share my enthusiasm as a probably an old school traditional addiction treatment type person, that's been at this since it's embarrassing to say the late 70s, that really sees something that could be an important game changer in our field. So not to create too much hype or hyperbole, but I really am excited about what Michael's about to share with you all, and I'm really glad that you're here here today. So Michael, I'll turn it over to you, and I don't have to stop sharing my screen or anything like that.
Thank you, Mark. Really kind introduction. I will pull up my presentation. So today we're going to talk about safely leveraging the post-COVID regulatory environment in a way that will maximize patient impact, and in a way that utilizes technology. And this is really what Sonara is all about. And so I'm Dr. Michael Giles, the CEO of Sonara Health. I'm also a psychiatrist. I founded the company in November of 2020 based on my experience in residency training, where I got to work in an opioid treatment program. And it was a very unique and striking environment to train in for me, notably because most of my new patients were leaving treatment for totally healthy reasons that as a psychiatrist, I wouldn't really feel comfortable discouraging them from pursuing. And so these reasons included things we're all familiar with, like the patient got a job and they couldn't come to the clinic every day, and they had to go to work instead, or maybe the patient had children they needed to take care of. And I would always work with the attending physician and try to advocate on the patient's behalf to get the patient more take-home doses, as much as I thought was safe. And I frequently ran into an issue of patient-provider trust. And it seemed that in order for patients to really get more take-home methadone and stay in treatment longer, a tool needed to be developed that would allow patients to demonstrate to the provider that they were handling their medication responsibly, that they were doing what they needed to do to stay and achieve recovery success, and ultimately get more take-home methadone. And so that's exactly what Sonara was founded to do. We launched in we launched February of 2022 as part of a study done by Stanford and Oregon Health and Science University. And that study went really, really well, and we've since rolled out to clinics across the United States. And so Sonara, our company name, is derived from the Spanish word soñar, and is the future tense of the verb to dream. And so we like to ask, what are the dreams of the future for patients at an OTP? We think it's the ability to be a productive member of society, to be valued, and really to be trusted. We want to enable patients to dream of a future where the pursuit of recovery at an OTP is actually freedom enhancing, where the pursuit of recovery is more appealing and liberating than continued illicit opioid use. So we all know how terrible the worsening opioid crisis is. In 2020, more patients between the ages of 20 and 50 died from an opioid overdose than from COVID. And so the federal government has really had no choice but to recognize this. And they have been enacting a series of regulatory changes since 2020 that have given providers at an OTP increasing levels of autonomy regarding treatment planning, most notably around take-home medication and toxicology testing. And so the first of these regulatory changes was in 2020. It was the COVID-19 public health emergency exemption, which actually expired last Friday. But this categorized patients into two groups that we're all familiar with now: stable patients who could receive up to 28 days of take-home methadone, and less stable patients. Providers had the discretion to really define what less stable and more stable was, and they really didn't have a time and treatment requirement, which was pretty revolutionary. And SAMHSA and the scientific community in general learned a lot during this period. And what we saw was that less than half of providers actually utilized these exemptions. But for the patients that were given exemption take-home doses, we actually saw improved outcomes. And so SAMHSA followed up with a notice of proposed rulemaking that was published in December of 2022. Again, it was largely in response to the public health emergency exemption data, which was very encouraging. It adopts a more liberalized take-home schedule, slightly more conservative than the public health emergency schedule. But by and large, it's seven take-home doses are permitted on day one. After a month, patients can get 14 take-home doses. Up to a month, between a week and a month, patients can get 14 take-home doses. And then after a month, patient get 28 days of take-home doses. Another really interesting aspect of the notice of proposed rulemaking was the removal of hard toxicology testing consequences. This is really a recognition by SAMHSA that not all substance use disorders present an increased risk of harm to patients when being given take-home methadone. And so we'll talk about what that means in terms of OTP workflows here in a little bit. And now we're in the situation where the public health emergency has expired. Again, this expired May 12th. And so SAMHSA is now enacted with what they call methadone take-home flexibility as extension guidance. Not very catchy, but it's active now for 1 year or until the notice of proposed rulemaking is finalized. And it's largely similar to the NPRM. It's almost like a trial period of the NPRM, so that SAMHSA can learn what works and what doesn't work from this new proposal. And one of the really interesting things that SAMHSA says in this new guidance is risks of a patient losing access to medication continuity should also be considered. And this is really a formal recognition that patients who drop out of treatment are actually it's like the worst possible outcome almost. Although we're always afraid of patients overdosing or diverting, the consequences, the frequency of patients overdosing in a methadone clinic is quite low actually, and diverting is a genuine problem. But the problem we see more frequently is dropout, and patients who drop out are 3 times more likely to die of an opioid overdose. And so really, SAMHSA is really trying to encourage clinics to adopt workflows that reduce patient dropout as aggressively as possible. And we also have some legislation that's been proposed. It's called the Modernizing Opioid Treatment Access Act. This has been proposed for the last 2 years. It gets a little more traction every year, but it's quite radical. So this legislation proposes that take-home methadone be prescribable by all addictionologists, and that retail pharmacies are also able to dispense take-home doses. It still requires enrollment at an OTP, but again, it really decentralizes a lot of the core components that we traditionally thought of an opioid treatment program. And it's unclear if this legislation will pass. It's just something to be mindful of. And so these ongoing regulatory changes have really targeted 3 key challenges. The first and probably largest is access. And there's a really great study done by Johns Hopkins. It really highlighted the effect of difficulty accessing an opioid treatment program for patients. And so what they saw was that for each 33 minutes of additional travel time to the opioid treatment program, patients were retained in treatment 2.3 months less. That's huge. And so what this means from our perspective is that if we can help patients travel to the clinic less frequently, we're going to save a ton of lives. The other thing that these regulatory changes target is they try to reprioritize the importance of co-occurring substance use disorder in the face of a fentanyl epidemic. And so we know that fentanyl has made it really difficult to keep patients in treatment. It's much more accessible, unfortunately, than care in an opioid treatment program is. Patients use it to self-medicate. And then to compound this challenge worse, historically, patients who've tested positive for other substances aren't given any take-home doses, which really has encouraged them to try to self-medicate even stronger from using fentanyl or other illicitly acquired opioids. And then the last kind of target for these regulatory changes is stigma. And so we're all very familiar with the stigma our patients face from family members or employers who learn that they're receiving care at an opioid treatment program. And SAMHSA is really hoping that the encouragement of the adoption of telehealth workflows will help reduce this stigma. And so OTP workflows are going to need to change significantly to leverage the new regulatory environment. And I think we'll need all the help we can get, not just from companies like Sonara, but I think at the county level, at the state level, it's a really big change that's being asked of opioid treatment programs, and we just want to help make that change however we can. So the first big change that clinics are going to have to figure out is how to enable more take-homes. And so with the current extension guidance, all patients are eligible for take-homes on day 1. Of course, it wouldn't be safe to give all patients 7 days of take-homes on day 1. And so that's, the challenge here is for clinics to adopt take-home schedules that de-emphasize time of treatment while preserving patient and provider accountability. And so really the thing we're most concerned about is how is the patient handling their medication at home? Are they taking it on time? Are they missing doses? And if you have a reasonable degree of certainty that the patient is doing what they're supposed to do, the take-home medication, that is a meaningful improvement in kind of your assessment of how the patient's doing it, and you can actually give them more take-home doses. The other aspect that clinics are going to have to learn to adopt is flexible drug testing consequences. And so now take-home doses are predicated on conditions that increase harm risk. And so it's important to recognize that not all co-occurring substance use disorders present safety risks for patients with take-home. And so we need to learn to assess patients' substance use disorder severity on a case-by-case basis. Let's take cannabis use disorder as an example. Traditionally, patients, if they test positive for cannabis, they don't get any take-homes. But there's no meaningful pharmacological interaction between cannabis and methadone. And so we need to assess, like, how often is the patient using cannabis? Are they using cannabis so frequently that they don't have a clear mind, they're missing some doses, or are they using it less frequently and have a milder cannabis use disorder, something that doesn't necessarily interfere with their ability to take methadone in a predictable, safe manner? Stimulant use disorder, again, another example. While stimulant use disorder certainly is a terrible thing for patients, and in general is a safety risk, it doesn't necessarily present an increased safety risk when combined with take-home methadone. Stimulants are a CNS activator. Methadone is largely a CNS suppressor kind of. And so if the patient is a kind of a milder stimulant use disorder, and they're not using so many stimulants that they become psychotic and they can't reliably take the medication, it's worth considering giving them take-home medications. Benzodiazepine use disorder, almost always you should never give the patient take-home methadone. That is a very dangerous combination, of course. Similar with alcohol, depending on the severity of the alcohol. The third target for the new regulatory changes is really the encouragement of telehealth. And so SAMHSA has openly encouraged the adoption of these telehealth workflows with the hope that they will reduce stigma. We've learned that from numerous studies that telehealth increases the patient's sense of autonomy and creates more private treatment settings. And so I think there's an opportunity here to utilize unique telehealth workflows that really boost patient-provider trust, especially around responsible medication handling behavior, so that patients can get more take-home methadone doses safely and be retained in treatment longer. One of the challenges OTPs face, though, is that with the exception of Sonara, there are literally no OTP-specific telehealth solutions out there. And so there's just not, a lot of OTPs really haven't had the opportunity to leverage telehealth in a scalable, impactful way because of that. And so the vision of Sonara is really to responsibly expand access to life-saving methadone through remote observation. We want to boost take-home accountability, transparency, and trust between patients and providers. And we do that by actively reporting key indicators of the patient's recovery success. We want to improve the quality of care and patient retention. We also believe that by shifting patients away from daily visits into more asynchronous remote care interactions, we could reduce the administrative burdens associated with caring for patients having OTP. And then we want to really ensure that whatever solution that we deploy is mindful of the needs of more disadvantaged patients. So it needs to be work for patients who don't necessarily have smartphones. We need to figure out a way to get them smartphones. It needs to work well for patients that don't have higher than a second grade reading level. It needs to work on these low cost phones that are given to patients as part of the Affordable Care Act. We really need to be mindful of all the patients' needs because we serve a very unique and vulnerable population. And so Sonara is a patented web-based application that enables remote observation of at-home dosing. We have tamper-aware labels that are applied to the methadone vial. Phil can show them if he's in our room right now. Again, this is all designed to enhance trust and accountability of take-home dosage of medication. And again, it was designed to support adoption amongst the more vulnerable and disadvantaged patients. And so we've recorded over 30,000 take-home methadone doses to date. We have hundreds of patients using the platform daily. We're active in 10 treatment centers. and we've received 2 NIH-funded awards. One was called ROAM, which is Remotely Observed Methadone Evaluation. That work is finishing up. It was done in Oregon. The results were very promising, and it showed the patients really found Sonara to be a meaningful support mechanism, and they liked that clinics gave them more take-home doses quicker than they ever would have received without being Sonara. And then we've applied for our phase 2 NIH-funded study, which is really going to be looking at items of interest to insurance groups, such as reduced travel cost, time and treatment retention, et cetera. So now I'll pull my screen up and do a quick demo. Any questions about what's been presented so far? I know the regulatory stuff can be particularly troublesome, and so I'm happy to think about that with anyone as well. Cool. So this is Sonara. It's a
Sorry,
web
I do have
application.
a quick quick question. When you were talking about the take-home medication being eligible on day 1, is that on the proposed the one that hasn't been approved yet, or is that like effective already?
It's effective already. So the public health emergency expired May 12th, and so SAMHSA said that for a period of 1 year after the expiration, something very similar to the NPRM will be active. I'm happy to post a link to that in the chat if that's helpful.
Yeah, okay, because like our state authority has been like, because the new like most recently said something about like 0 to 14 days, but we were still under the impression that it was like 14 days or a month before they're eligible. So I think like the state might have a misunderstanding if that's the case.
Oh, yes, that's a very important consideration. So the states can do whatever they want still.
Okay.
So for states that opted into the public health emergency, unless their SOTA says otherwise, these rules are automatically in effect, but the SOTA is free to enact more strict requirements. And here's a link to, I put it in the chat. There's a link that discusses what the current state of the take-home flexibilities are.
Awesome. Thanks so much.
My pleasure. So this is the Sonara web application. Being a web application is notable because patients don't need to download anything. They don't need to have any free space on their device. They just need to go to sonara.app and they log in. And then they can begin the remote dosing experience. And so I'll press play on the video. We do a quick camera mic test. Once this test is complete, everything from that point forward is recorded on our cloud servers, not the patient's device, and saved so that the provider can then review the video whenever they feel like they need to. And so I'm going to pause here. This is a take-home methadone vial, but what's different about it is this green label that's been applied to it. And so when we implement in a clinic, we provide the clinic with a roll of these labels. Each label has a unique QR code on it. And so when it's being scanned, we're seeing if that QR code's ever been used, and then we're digitally voiding it so that it can't be read. And so the scan is successful. The patient brings the vial into the frame. And this isn't a real patient. This is one of the co-founders. So we open up the medication vial. I'm going to pause here again. You can see that when the label is removed, void residue is left on the vial, and the QR code also gets destroyed. And it's just another measure of diversion prediction. So we'll pretend to take the medication. In this case, the patient shows that there's no medication remaining in the vial. And then they say a quick phase to reduce the risk of cheeking. So brown fox jumper for the lazy dog. Once that's complete, we have the opportunity to collect patient feedback, and we've built out the feedback section quite a bit. So we collect demographic data when we feel like it's pertinent, and we can even throw in other forms of assessment there. And the patient can leave feedback. We've seen very interesting feedback comments that we'll discuss when I get to the clinician dashboard. But patients will say things like, "Oh man, I really enjoyed sharing this with my provider," or "I've been praying for something like this." Or we see other comments like, "I have cravings, I need a higher dose," which has some really interesting clinical implications. And then in the final screen, the patient's asked to return back to the application, in this case, between the hours of 6 a.m. and 11 p.m. And this is actually very similar to the dosing hours that most of our customers have opted for. And that's notable because typically clinics open from like 5 a.m. to 2 p.m., which is restricted for certain patients. And in this instance, patients have much more freedom to take the medication when they feel it's appropriate. Any questions about the patient side of things? Pull up the clinician environment real quick.
That's like really cool. Is there interoperability between like the QR codes and like different EMRs? Like, is that a challenge, or is that not really an issue?
The way we've configured the clinician environment makes EMR integration not really needed. You'll see. We do have, we're working on EMR integration with Methosoft or the analytics software, but that's not complete yet. And that should be complete in the next few months, that we'll see. They are slow. So this is the clinician environment. This is Phil Beck. He's not a patient. He leads growth here at Sonara. And this is what a good example of what the patient's dosing profile looks like, though. So here we have a dosing timeline, and each color represents a different status for the dose. So green means that the patient uploaded a dose. It was reviewed by a provider, typically a counselor, and accepted. Red means that the dose was reviewed and then rejected. And most often a cause for a rejected dose is a training error. And so over time, patients learn to use the solution more just correctly and in a way that builds trust. And then yellow means that the dose was supposed to be recorded by the patient, but wasn't recorded for whatever reason. And so I'll show you what it looks like to review a dose. And so you can watch the scan video. And so here, if this was a real dose, you'd reject it because you can tell that this vial has been opened many times. You see the void effect, which indicates that the vial residue is left, and maybe the patient needs more support because they opened the medication before they should have. Typically, we don't see that. Almost, I would say 85 to 95% of our doses are ideal. And so this is what looks like to watch a patient take the medication. By default, the video plays back at 1.5 speed. You can go all the way up to 4x. And so our average dose recording time is around a minute, but at 4x, it takes 15 seconds. So it's a very expedient process. And here's an interesting message from him. I'm feeling a bit lightheaded after taking my dose. So in that instance, you might want to reach out to the patient, see what's going on. Other interesting messages we've seen are, I have cravings, like my dosage increased. And so normally when a patient has that type of complaint, or one of the things providers are concerned about is the patient actually taking their medication. And some providers might opt to have the patient come in and do urine toxicology screening to confirm that they're taking their methadone. In this instance, that's not necessarily required. You have a recording of every dose the patient's taken for the last few weeks. So with a reasonable degree of certainty that increasing the dosage makes sense. We also have an alerts page. And so anytime something doesn't go smoothly during the recording process, or anytime a patient leaves a message and alerts generated, the provider can click on it and investigate it, and then flag for follow-up if they feel like that's warranted. And so then they'll have a nice list of all the elements that require further interaction for their cohort of patients. And so you can actually sort patients by who they've been assigned to as well. So you're not always having to look at the entire cohort at a specific clinic. So if a counselor or dosing window nurse has a certain group of patients, they can just click that and look at those patients. And then here we have the submitted view. This really allows fast back-to-back processing of the doses. So you would click review on a dose, you accept or reject it, and then you just go to the next dose. So you, for your entire cohort or group of patients, you could just process them pretty quickly. And so on average, our patients have double the number of take-home doses compared to patients who aren't on Sonara. And so as you can imagine, we're seeing all sorts of useful, meaningful outcomes, increased patient satisfaction, of course, but also we know that more take-homes equals improved retention. And so we're confirming this with our latest batch of NIH work. Any questions about that?
In terms of the counseling component, do you require your patients to do anything in person?
That's up to the clinic. So we aren't we aren't providers. I mean, I'm a psychiatrist. I'm technically a provider, but my work through Sonara is not as a provider. And so yeah, we adopt, create implementation protocols and workflows based on whatever the clinic's needs are. And so some clinics might, all clinics so far require in-person assessments still, but just the frequency at which those occur is a lot less when they're on Sonara. Did that answer your question?
Yes, somewhat, yeah.
So then the last thing I would like to talk about is on one of our current studies, which is part of the NIH I-Core program. And so we are, the nature of this study is we have to interview 100 different stakeholders in a short period of time. And so if anyone is interested in interviewing for this I-Core program, please let us know so we can set aside a time to have like a brief, like 5 to 10 minute conversation with you to get like individualized feedback on some of the things that we discussed here. That's all I have for the presentation. So we can have a discussion, or we can end early. I can give the time back to you guys, whatever works best for you.
I have another question. In most clinics that utilize this, only doing this for like the higher risk clients with take-home medication that maybe wouldn't have earned medication otherwise, or are they doing it like kind of across the board, like any client that has take-home medication? So I could say like we have almost 6,000 clients. So I feel like with some of our counseling panels, you know, of 100 more clients, that might be difficult, but I could see it being really beneficial with kind of like higher risk clients that we're kind of giving take-home medication to that you know, that maybe we feel a little uncomfortable about, or at least changing, or the, you know, paradigm shift and all that.
No, that's a really good question. And our most successful clinics utilize Sonara for patients where they think it will meaningfully change the treatment planning, i.e. that's generally high-risk patients. So yeah, high-risk patients is the first group. Then the other group where they feel like it will really change treatment plans are new patients where you aren't sure what level of risk they are. When you see that the patient's taking their medication every day, you then have a really more informed understanding of what risk that new patient is at. And so that's where we've seen the most success is new patients, and then these high-risk patients. So patients who don't have 28 days of take-homes. I think Sonara is not useful for those patients at all, but patients who have maybe only a few days of take-homes, we see great success in that group of patients.
Very cool. What are the challenges? Like what has like kind of not, like you've talked a lot about like what's worked, like what hasn't worked, I guess. Like is there any challenges that specifically could be beneficial to highlight? Or
yeah, so a lot of the challenges we initially encountered were technological and kind of patient population specific. So these patients aren't, or at least are the patients we've encountered so far, tend not to be using like the latest iPhone or most recent Samsung Galaxy phone, they're using like low cost devices that require a lot of ingenuity and like software engineering to get something to work. And they often have like poor connection speeds, or like 2G or 3G. And so we did a ton of work getting our solution to function reliably on these low cost devices. The other thing we learned was around the creation of regimens on our platform. And basically, we saw that our clients who were using like Methasoft or SAMS, they all have a very similar way of creating take-home methadone regimens. It's almost like a set and forget system. And so we just mimic that almost exactly so that if you're familiar with how to use either of those solutions, you automatically know how to use Sonara. And then I think the other thing we've learned, and this is probably the most significant one to me, is that there's the OTP space is changing super rapidly in clinics because they're about caring for patients. They don't really necessarily have time to keep track of like all the minutia with regarding the regulatory changes. And like, I'll talk to one clinic in a city that has an understanding of the regulations, and another clinic next door that has a different understanding. And so like, I feel like there's a lot of confusion, and that clinics need more support and guidance at the state and county levels regarding like what is actually permitted for take-home methadone and just care paradigms in general.
I have another question. So the observing part of the medication is done by whom? The clinical staff or nursing staff?
Ultimately, it's up to the provider's preference. What we do is we just listen to what the provider wants and then create a workflow around that. We've seen the most success with counselors doing it because counselors tend to be decision makers, and they have a more personalized understanding of how well the patient is doing. In states where case management is allowed, case managers are a really good resource for Sonara as well. And in Oregon, the peer navigators are actually using Sonara to monitor patients. So it really varies from clinic to clinic.
Yeah, because what's interesting about that is that like it's not they're earned bottles that clients have, so it's not like normally they wouldn't have anybody watching, so it's not like a nurse or a medical person kind of has to be watching in a certain scope of practice concern or something like that. There are a couple of questions in the chat too. I don't know if you saw those, but Amanda asked what's some of the feedback from clients on the kind of from the client experience perspective.
I mean, the feedback is really positive. It's one of the more common sentiments is patients surpassing expectations. And then the provider's often really surprised at how much the patient enjoys it. Like I was even surprised by it. But when I think about it from like a psychiatric perspective, it makes sense. So like one of the diagnostic criteria of a substance use disorder is like the pattern of substance use has resulted in a loss of trust, like from family members, from the community, from colleagues, from friends, et cetera. And patients really value the ability to prove themselves right. These patients feel like no one trusts them, and that like everyone thinks they're here to like mess something up. And so patients almost like love to prove people wrong on Sonara, and providers are often really surprised by that. What happens if they don't take doses via the app consistently? Is that determined by the clinic? Exactly. Most often when if a missed dose is like a one-time thing or a training issue, but in instances where there's a pattern of improperly utilizing Sonara or take-home doses, patients will get reduced take-home doses in that case. That's the minority of patients. Again, I think around 5 to 10% of our patients, we find out that they need more support, which is actually useful because if 100% of our patients didn't need more support, then you would need Sonara. You could just give everyone the maximum number of take-home doses. But we know that certain patients need more support than others. And so Sonara is very helpful in identifying those groups of patients.
Michael, you've been, I guess I have a question. You've been working with a lot of different clinics across the country, from San Francisco to Oklahoma to Massachusetts. And I guess I was wondering, is there variation in the degree to which the clinics seem to, be willing to take this on? Because any change of any kind for any of us is often complicated, for better or for worse. We just don't change very well. And I guess I'm just kind of curious what you've noticed in terms of factors that influence whether Sonara has been, kind of an easy, we call it adoption, easy for places to pick up and integrate, or it's been more challenging. And what do you understand accounts for that?
That's a really good question, Mark. Yeah, so if we were to look at our customers and try to understand like the spectrum of success we've seen, from customers that aren't doing as well to customers that are doing really, really well, the customers that tend to do really, really well are impact focused. So like often medium-sized nonprofit groups do really well. Groups that tend to struggle more are more about like the bottom line. Or they manage a bunch of clinics that are like really heterogeneous. And so like a good example is one of our Chicago clinics, Family Guidance Center. They really leveraged Sonara to its fullest and like recreated some of their core clinical workflows to enable this asynchronously observed take-home dosing. And they give Sonara to most new patients. And they're seeing really cool things in terms of the effect on patient retention. And, they're going to roll us out to the rest of their clinics here soon. But then we have other clinics where, like, for whatever management reasons, it's hard to enact new changes. And it's almost like it's not like a Sonara issue. It's just clinics that aren't good at enacting new changes, generally speaking. I don't see the really encouraging impacts to the same degree that other clinics do. I don't know if that answers your question, Mark.
Yeah, I mean, I think we know it in implementation that there's usually a combination of things. The patient has to like it and benefit from it. There has to be leadership support. I think the people who are the providers, whether they're nurses or counselors, kind of frontline folks, have to see the benefits. And like you said, there's a bottom line issue, and I guess related to the bottom line issue, I wonder about reimbursement for in clinic dosing versus take home dosing, and if that's proven to be an obstacle for the for-profit business-oriented clinics.
Yes. Like often who gets Sonara is determined by who can get reimbursed for using Sonara at the for-profit clinics. Whereas at the nonprofit clinics, the question that's being asked often is who will benefit from Sonara, not who can we get reimbursed from using Sonara.
Right. So that's the way a lot of healthcare works. So I suppose that's no surprise.
Is there reimbursement? Like I may have missed.
It depends on the state. In states where there are case management is something that
I may have missed that. Okay.
So yeah, it's very state specific, but so like in Illinois, we're helping our clinics get reimbursement. In Oregon, we're helping some clinics get reimbursement. In other states like California, clinics only get reimbursement through state opioid response grant funds that they have to apply for Sonara, which is something also that we help our customers pursue of interest. It just varies a lot, but I would say about half of our customers get additional reimbursement from using Sonara. And it makes sense, right? Like the increased level of care that these providers are giving should be rewarded. It's all about really aligning incentives to maximize patient recovery success. So. Any other questions?
Was there any noted difference that clients reported in their relationship, like with their counselor or with the case manager that was that they were assigned to work with in the clinic? With obviously with the take homes, but still monitoring over this platform, did they note any difference in their therapeutic alliance?
That's a really good question. I don't think we probed that directly. So our phase 1 study was largely done with qualitative interviews, and that certainly was a sentiment that came up. We didn't quantify it. And that's something that I think I will probably ask as part of our follow-up interviews. I really like that. I think probing that directly makes a lot of sense. It's a very impact-focused question. I like it.
Well, thank you.
I have a whole bunch of data I could have shared on these studies, but I figured it would be just a numbers game. It wouldn't be particularly interesting, but happy to share that as a follow-up if interested as well.
You mean data about like outcomes and stuff with?
Yeah, acceptability, feasibility, sentiment, kind of assessment.
Can you send that
I'd be
over, Mark?
interested too in like what other clinics, like, I mean, I'm the director of nursing, by the way, and thank you for your presentation, but it'd be helpful to talk to some clinics who've had success to kind of see, because I mean, it seems like there's a lot of different kind of ways to individuate the use of it, depending, again, one of the things that's challenges, we have like, 10 clinics, soon to be 11, and as you said, one of the challenges potentially is like, if those are siloed a little bit, part of anytime we implement anything, it's just there's 11 clinics, and so do you pilot at one and stuff like that. But I'd be interested in kind of hearing some of the successes and challenges from the source.
Absolutely, yeah. We like if talking to other clinics that use Sonara is something that's interesting, we will set that up. We'd be happy to set that up. Cool. This was fun. Yeah, so here are some statistics. So 94% of patients in the Realm study, which was the one that Mark conducted, Mark and Dennis, 94% of patients report that Sonara improved their lives. 89% of clinicians agreed that Sonara added value. And the treatment cohort in the study population, like less than 2% dropped out over 2 months, which is good.
Is that in comparison to normal, or just like less than 2% in general?
Just in general. It was a smaller scale study, so we didn't really have big enough data to compare it to like matched time and treatment population or anything. But it's a promising metric, I think, nonetheless. And then our Oregon payer pilot, similar findings. Again, it appears that what we saw with Rome is generalizable. And then our Rome study, which I don't have a slide on because it just finished. Again, largely the same results. And so yeah, we've looked at this across a number of clinics in the United States now, and similar findings repeat themselves. So I'm optimistic that we're onto something here. I'm happy to give this time back if we feel like that's what's best. What do you think, Mark?
Yeah, no, I think people always appreciate that. And, as you counselors know, silence is a form of communication. So we should probably attend to that. We don't want to hold people just because the thing goes until the bottom of the hour. But I don't know what the culture is, but I think, Darcy, you said that if it ended early, it ended early. We don't have to.
Absolutely. We have many folks who have done that.
Okay.
Cool.
Well, thanks for joining us. Really, I was looking for some names that I recognized, and I have to say I don't recognize anyone's name, but that might be just that because it's like 10 years. So if you're still working at Hartford Dispensary after 10 years, congratulations. Or Root after 10 years, congratulations. It's a great place. So yeah, Darcy, you have contact information. I don't know what was sent out in terms of an announcement about both of our backgrounds, but emails I think are on the announcement. So feel free to pass those on. I know Chris sounds like he wanted to follow up, but if there are others that want to follow up, really great questions. I think Michael, you probably got some ideas about different things to include in future projects in terms of measurement and as you said, impact. Really important question there.
Yeah, 100%. This is a really fun conversation, and hope to talk to you guys more in the future.
I hope we can continue that conversation. This has been great. Thank you, guys.
Thank you.
Thanks,
Thank you.
everyone. Enjoy
Take
the
care.
day.
I think that's
Wonderful.
a really interesting idea.
Thank you.
Yeah, very interesting. Now, for the labels itself, is it like pretty much once you release it, it's inkjet? It's pretty much stuck onto the label itself, or?
The labels are it's like a roll of stickers essentially, and then the dispensing nurse puts it on the methadone vial, and that's it. And so if the patient takes the label off, then you see the void effect and all of that.
Okay.
It's essentially putting a sticker on the methadone vial. We did a lot of work to make sure it was like as minimum disruption to the standard workflow as possible.
I won't lie, I'm probably going to be thinking about this now for like the next few hours because it's, again, it's an outside the box idea. It's something very new. I may reach out with more questions and just because like I'm still kind of taking it all in and processing it.
Of course, yeah, happy to talk to any of you one-on-one. I enjoy talking about it, so don't hesitate to reach out.
Okay, cool. Thank you.
Thank you.
Thank you,
everyone.
Thank you. Bye, you guys.